Good morning, everyone out here. Myself, Dr. Ankita Gogoi, and the title of my paper is Pupil Cycle Time and its Significance in Patients with Diabetic Retinopathy. A small beam of light focused at the pupillary margin will induce regular persistent oscillations of the pupil. The average period of these cycles is known as pupil cycle time or PCT. PCT is remarkably stable and repeatable within plus minus 3% variability. When the iris muscles are normally innervated and responsive, the PCT is dependent on the speed of nerve conduction and the number and strength of optic nerve impulses. It can be easily measured and expressed in milliseconds. Prolongation of PCT may result due to impairment of the afferent or efferent pathway of the pupillary light reflex by some diseases including optic neuritis, optic nerve compression, space-occupying lesion, multiple sclerosis, CNS depressants, progressive autonomic failure, and diabetic autonomic neuropathy. PCT is a fast, simple, reliable, and non-invasive clinical test of optic nerve function and is a sensitive measure of dysfunction of the parasympathetic afferent limb of pupillary light reflex. It has the great advantage of being objective and quantitative for each eye individually. The aim of the study is to evaluate PCT in patients with diabetic retinopathy and its role in detecting diabetic autonomic neuropathy. The authors have no personal, financial, or institutional interest. It's an observation institutional cross-sectional study. 50 eyes of 50 known type 2 diabetic patients with different grades of diabetic retinopathy were selected for the study. All patients underwent ophthalmological examination including BCVA, pupillary light reflex, slit lamp, tonometry, fundoscopy, and PCT measurement. Patients with associated ocular pathologies, ocular trauma, ocular surgery, neuro-ophthalmologic disorders, and patients using drugs that can cause autonomic dysfunction were excluded from the study. The procedure: the patient sits at the slit lamp in a dimly lit room and is instructed to look into the far distance. A thin, narrow, horizontal aligned slit of light is focused accurately on the lower part of the iris in a plane perpendicular to it. The beam of light is slowly elevated until it impinges on the pupil for the initiation of pupillary constriction and dilatations. The pupillary oscillations are observed when the time for 100 cycles of oscillations and dilatations is measured with a stopwatch, and the mean PCT is calculated by simple division to obtain PCT in millisecond per cycle. So these are the pictures. The results: the age of the patients were ranged from 42 to 74 years. The largest number of patients were 21, which were in the age group of 61 to 70, followed by 19 in the age group of 51 to 60, 7 in the age group of 41 to 50, and 3 patients in the age group of 71 to 80. It comprises of 22 males and 28 females. On examining the fundus, 18 had mild diabetic retinopathy, 22 had moderate diabetic retinopathy, 7 had severe diabetic retinopathy, and 3 had proliferative diabetic retinopathy. 2 patients had diabetes for less than 1 year, 21 patients had between 1 to 5 years, 20 patients had between 6 to 10 years, and 5 patients between 11 to 15 years, and 2 patients had diabetes for more than 15 years. The mean PCT of the 50 patients was found to be 1130 milliseconds with a standard deviation of 186 milliseconds. And 5.5% of the patients with mild NPDR, 63.6% of patients with moderate NPDR, and 100% of patients with severe NPDR and PDR had PCT value of more than the average mean. And a positive correlation was also seen between PCT and the duration of diabetes. Discussion: the average pupil cycle time in males is around 928.4 milliseconds and in females it is 934 as per study of AK Sood in 1985. In the present study, mean PCT of the diabetic patients is 1130 milliseconds with a standard deviation of 186. Thus, in our study, PCT is prolonged in diabetics. Similar findings is cited in many other studies like S.A. Smith, Martin C. and L. and Kim G.C. et al. 5.5% with patients with mild NPDR, 63.6 patients of patients with moderate NPDR, and 100% of patients with severe NPDR and PDR had PCT value more than the average mean PCT, signifying prolongation of PCT with increased severity of diabetic retinopathy. In the present study, a positive correlation was also noticed between PCT and the duration of diabetes. Thus, it is seen that there is lengthening of PCT with increasing duration of diabetes. So I'm concluding saying pupil cycle time is prolonged in diabetics and has been shown to increase with duration of diabetes and increasing grade of retinopathy. The lengthening may be due to pupillary autonomic neuropathy. Thus, PCT is one of the important diagnostic method of pupillary function. It is simple, inexpensive, yet quick and effective tool to assess the pupillary autonomic neuropathy in the diabetics. These are my references. Thank you.
So there was significant p-value difference because the normal was 930 and yours was 1130 milliseconds.
Yes, sir. But we didn't take any control group, sir. Our control was like what was found in the previous studies.
Okay, thank you.
Thank you, sir. No, sir, I didn't know video. Okay, okay. Yes, sir, yes, sir. The patient sits in a dimly lit room, and a horizontal thin section of the light is impinged just upon the iris level. And then, like, we impinge into the iris level, and then the constriction starts. Once constricted, the iris blocks the light, and then again it starts dilating. So, we like this, we calculate the time taken for 100 constrictions and dilatations, and we divide it by 100 to get the PCT value in milliseconds per cycle. Thank you.
Second suggestion is have a control. Randomization, these are the highest level of evidence literature. Yes, yes, yes. Your name? But you are not in the chief author. Okay, okay, it's all right then. Okay. Timing का है? Chief author is okay. Dr. PM Baba. Supporting author is no problem. एक बार आप यहाँ आके चेक कर लीजिए ना. सर करवा देंगे हम. एक बार वहाँ से कर लो. नहीं चल.
Hello. Hello. Am I audible? Hello. Hello.
Hello? Okay. Shall I start, sir?
Yeah, timer reset कर दीजिए.
Okay. Good morning, everyone. I am Dr. Priyambada Subudhi, and I'm here to present a rare case of incidental diagnosis of guided retinal atrophy. I have no financial disclosure and no conflict of interest. Now, guided atrophy of choroid and retina is a rare autosomal recessive disorder resulting from the deficiency of the enzyme ornithine aminotransferase. It was first described by Fuchs in 1896 and is characterized by high myopia, typical retinal and choroidal lesions, early cataract formation, and most importantly, hyperornithinemia with levels as high as 10 to 20-fold above the normal. In this case, a 13-year-old girl was detected with bilateral myopia and prescribed spectacles during rural school health screening 3 years ago. Her distance vision rapidly deteriorated and she developed night blindness in both eyes 1 year ago, for which she was referred to our tertiary eye care hospital. The best corrected visual acuity in both eyes was 6 by 60 with minus 3.5 diopter sphere. There was no color vision deficiency in both eyes, and the anterior segment examination was unremarkable in both eyes. The pupil reaction and intraocular pressure were within normal limits in both eyes. The dilated fundus examination showed sharply demarcated areas of choroid and retinal atrophy in both eyes, sparing the macula with thin areas of pigment between those atrophic areas. Now, she was advised a Humphrey visual field 24-2 in both eyes, which showed constricted visual fields. As the visual field in left eye was highly constricted, she was advised a 10-2, which also showed a constricted visual field. On fundus fluorescent angiography, the patches appeared as hyperfluorescent with faint hyperfluorescent borders. The electroretinogram response was within normal range. There was a significant increase in serum ornithine levels, which was 646 micromole per liter. There was no systemic or intellectual abnormality detected in the patient, parents, or her younger brother. Now, coming to the differential diagnosis, we have two diagnosis of guided atrophy, that is choroideremia and myopic fundus changes. In choroideremia, it's a rare X-linked recessive disorder which is characterized by night blindness, visual field constriction, and visual acuity loss, which may confuse with guided atrophy. In advanced stages of the disease, resemble later stages of guided atrophy, but the well-demarcated round lesions observed in our patient are not characteristics of choroideremia. In myopia, patients with high myopia may present with peripheral clusters of atrophic areas or paving stone degeneration that may resemble the lesions seen in guided atrophy. But paving stone degeneration is typically found between the ora serrata and the equator, while in guided atrophy, the lesions are more concentrated in the mid-periphery. Now, the patient was started on high dose of vitamin B6, 300 milligram per day, and dietary advice about low protein consumption, that is an arginine-restricted diet, was emphasized. Now, guided atrophy is a rare progressive metabolic choroidal and retinal degeneration resulting from the deficiency of the enzyme ornithine aminotransferase mapped onto the short arm of chromosome number 10. The inheritance is an autosomal recessive pattern, and its main manifestation is a gradual loss of vision, night blindness, and tunnel vision. There is subsequent development of posterior subcapsular cataract by the second decade, progressive constriction of the visual field, and eventual loss of central vision in the 4th to 5th decades of life. A 10 to 20-fold rise in plasma ornithine levels is characteristic. The administration of pharmacological doses of vitamin B6 is an established procedure, as ornithine aminotransferase is a B6-dependent enzyme. Wellaber et al. Reported that 3 out of 7 patients responded to oral B6 supplementation with over 50% reduction of serum ornithine. As ornithine is synthesized from arginine, an arginine-restricted diet may decrease the plasma ornithine levels to normal values. This case emphasizes the importance of correct diagnosis, screening of parents and siblings, and early institution of treatment in guided atrophy, as it slows down the progression of retinal degeneration and prevents complications of the disease. So my take-home message would be school visual health screening, prompt referral, and awareness on willingness of the parents are essential for the early diagnosis and treatment of this rare genetic disorder. These are my references. Thank you.
What will happen if you don't treat in this case?
Sir, in this case, like the disease is a progressive disease, so this will continue progressing, and ultimately there'll be a tunnel vision, and the visual fields, as we can see in this case, it was already very constricted. So if we do not treat on time, this will continue progressing and will ultimately lead to blindness. Sir, I haven't come across the role of Octa in any of the articles that I have gone through. Sir, because the patient came for myopia, so we on just a fundus examination we saw these characteristic lesions. The patient, it was an incidental finding. Yes.
Okay,
Thank you,
for the
sir.
patient.
Next is Dr. Sheetala. She'll be presenting on hypertension. Hypertension, potential for CSCR.
Hello. Shall I start, sir? Good morning, everybody. Myself, Dr. Shitla Yumnam, will be speaking on the topic hypertension, attention for CSER. I have no financial interest. Hypertension, uh, central serous excuse me, sir, it's not working. Central serous chorioretinopathy is an idiopathic disorder characterized by the localized serous detachment of the sensory retina at the macula secondary to the leakage from the choriocapillaries through one or more hyperpermeable RPE sites. It's more common between the age group of 20 to 50 years with male is to female ratio of 6:1. It presents in acute and chronic form. The use of steroids, psychological stress, renal dialysis, pregnancy, age, pylori vector infection are some of the risk factors. Hypertension is an important risk factor in developing systemic vascular disease and ocular vascular diseases. Hypertensive choroidopathy leads to breakdown of blood retinal barrier in RPE, which leads to serous detachment and diffusion of subretinal fluid into the retinal tissue, causing retinal edema. Our aim is to study the association between hypertension and central serous chorioretinopathy or CSER. It was an observational study which included all the patients of CSER, both male and female of all age group, patients with known case of retinal diseases, diabetics, history of any trauma or intraocular surgery, and patients on any form of steroids were excluded. After satisfying inclusion and exclusion criteria, 40 cases of CSER were included in the study. Informed consent was taken from every patient. A comprehensive ophthalmic examination was done, which included best corrected visual acuity, slit lamp examination, IOP, fundus examination, OCT macula, and fundus fluorescent angiography. Histories of pre-existing hypertension and newly diagnosed hypertension was taken. Blood pressure was recorded 2 times at an interval of 24 hours. Based on JNC7 classification, hypertension was classified as pre-hypertensive, stage 1, stage 2, and hypertensive emergency. Coming to the results, 92.5% were turned out to be male and 7.5 was female among 40 cases. And the mean age of the study population was 45 years, with majority of the study population belonging to 41 to 50 years of age. And according to JNC7 classification scale, 17 cases were normotensive, 10 were pre-hypertensive, 10 were stage 1, and 3 were stage 2 hypertensive. Here is a fundus picture and the FFA of a patient with CSER, and OCT macula of a patient with bilateral CSER. Coming to discussion, firstly, out of 40 cases of CSER, 37 were male and 3 were female. A population-based study carried out in Olmsted County, Minnesota has also shown that male has 6 times more higher incidence than that of a woman. And secondly, the mean age in our study was 45 years, with the maximum study population belonging to the age group of 41 to 50 years. According to Gass et al. In his study, it also shows that the predominant involvement between the age group of 20 to 45 years. Thirdly, majority of the CSER patient, that is 57.5 in this study, had elevated blood pressure. MF Karadak et al. Have also suggested that increased blood pressure variability could be a risk factor for development of CSER. According to Ahmad Awasha also has published a study on bilateral simultaneous CSER in a teenage girl with a history of systemic arterial hypertension. I would like to conclude by saying that hypertension could be a possible risk factor in the pathogenesis of CSER, and it is predicted that prevalence of hypertension in 2025 to be increased by 24% in developing countries and 80% in developed countries. So early detection could prevent from progression of pre-hypertension to higher stages of hypertension. The diagnosis and follow-up of CSER relies mostly on multimodal imaging. OCT opens a new window in evaluating the choroidal thickness as well as in follow-up. It is highly recommended to screen early and act early, as majority of these patients are young adult and are unaware of their hypertensive status. Their blood pressure must be checked, as hypertension not only causes ocular symptoms but also has systemic comorbidities. Early lifestyle modifications must be advised, which includes regular physical activities, low salt diet and fat diet, cutting down on alcohol, etc. And regular follow-up must be done. Thank you.
Can you please elaborate your inclusion criteria?
Sir, I have included all the patients of CSER, the new cases as well as the old cases who come to our OPD.
And
And I have checked when they come and present to us.
how you classified the pre-hypertensive and the hypertensive?
Sir, when we check the blood pressure, first we record it at the time of presentation. Then, if the blood pressure, according to JNC7 classification scale, if their systolic and diastolic pressure was checked, and if it falls
There
in,
is variation all over the day, no?
yeah, so we have calculated twice. We call the patient again the next day and calculate it again. And if the blood pressure, if even the one is falling in any of the category, then we consider them whether it is normotensive, pre or stage 1 or stage 2. Yes, sir. Drug history, sir, no other parameter. Like we have asked if there are a known case of hypertensive, that also we have included in. No. We have excluded the other conditions.
Vascular problems associated with hypertension, right? Ischemic heart disease. How do you conclude that this hypertension is a risk factor for CSR? What is the...
Sir, because hypertension will, this choroidopathy leads to this breakdown of iron.
I'm asking about in statistical analysis, where you concluded that this
Yes,
is
because
correlated or associated or cause. There are different studies. How you, I guess, Sir was asking to other p-value or any correlation tests so that you can conclude.
sir, in our study that 57, more than 50% has found to have elevated. So,
So it's a univariate analysis.
hmm.
So how you measured that and how you validated it, your study. Okay, no problem. Okay.
Yes, sir. Sheetala, I know.
What one? Dr. Aishwarya Mohanty.
So shall I start? Good morning, everyone. Myself, Aishwarya Mohanty, is going to present on OCT. Can it be a predictor of eclampsia? There is no financial interest. Preeclampsia, with the prevalence of 3 to 8% of pregnancies, has become the leading cause of maternal mortality, especially in developing countries. It is a multi-system disorder which can also affect eyes and the visual system. Now, emphasizing the pathophysiology, reduced blood flow to placenta due to fibrous spiral arterioles. It results in placental hypoxia ischemia, which can lead to fetal growth restriction and in severe cases, fetal death. There is also release of pro-inflammatory proteins into the maternal circulation, leading to endothelial dysfunction and systemic vasoconstriction, eventually resulting in maternal hypertension. And due to local vasospasm, there is major organ damage like in kidney, retina, liver, and brain. Visual symptoms, which are usually most common in third trimester, include blurring of vision, photopsia, scotoma, diplopia. Ocular findings include conjunctival vascular anomalies, hypertensive retinopathy, exudative RD, vitreous and preretinal hemorrhages, ischemic optic neuropathy, and hypertensive choroidopathy. There are very few clinical studies on preeclampsia's retinal changes as the objective and quantitative retinal imaging methods were lacking. So with the advancement of OCT, an attempt has been made to study RNFL changes in pregnant women with gestational hypertension in the age group of 18 to 45 years and establish the potential contribution of OCT as an eclampsia predictor. It was an observational prospective study including all the patients diagnosed with gestational hypertension by the Department of Obstetrics. Pre-existing diabetes, hypertension, renal disease, or any other retinopathy were excluded from this study. And informed consent was taken from 35 patients after satisfying inclusion-exclusion criteria. Details pertaining to family history of hypertension, age, parity, gravida, and blood pressure were documented. Baseline data was collected. A comprehensive ophthalmological examination was done, including external examination, BCVA, slit lamp, IOP measurement, detailed fundus evaluation, and peripapillary RNFL thickness was measured at first visit at 28 weeks and 2 months postpartum by HD-OCT. The severity of PIH was classified into preeclampsia, mild and severe, and eclampsia according to ACOG guidelines. Now coming to results and discussion. Maximum of the study population belonged to the age group of 30 to 40 years, with the mean age being 32.48. The youngest patient in our study was of 20 years of old. There were 23 primigravida and 12 multigravida patients, and maximum of them belong beyond 30 years of age group. According to ACOG guidelines, there were 28 mild preeclampsia and 7 severe preeclampsia patients. On comparison of RNFL thickness from first visit to 28 weeks of gestation, in the mild preeclampsia group, 7 patients had thicker RNFL layer thickness, while 15 had no change, 6 of them had mild thinning. Likewise, in the severe preeclampsia group, 3 had no change and 4 of them had thicker RNFL layer thickness, out of which 2 patients were diagnosed with new onset of convulsions who were terminated emergently. The mean RNFL layer thickness in the severe preeclampsia group increased from 96 micron at first visit to 101 micron at 28 weeks, which decreased significantly to 98 microns postpartumly. This was found inconsistent with a study done by Arab et al. In mild preeclampsia group, there was no significant change during pregnancy and after postpartum. Now, highlighting the fundus changes, 13 patients had no hypertensive retinopathy, 7 had grade 1, 6 had grade 2, 5 had grade 3, and 3 of them had grade 4 hypertensive retinopathy. One of the study population were diagnosed with exudative RD on post of day 2 of LSCS. Similarly, Reddy reported that 53.4% of preeclampsia and 71.2% of eclampsia patients had retinal changes. These vascular changes in the retina, they typically correlates with the severity of systemic hypertension. Therefore, observing the retinal changes can help in assessing the disease severity. To conclude, I'd like to say that preeclampsia was more prevalent among the elderly primigravida in this study. Severe preeclampsia had thicker RNFL layer thickness during pregnancy, which decreased significantly postpartum. At the same time, there was no change in mild preeclampsia. An OCT with ocular fundus changes may be useful in predicting the maternal risk, diagnosing the patient early, and it can guide the obstetrician in early and prompt management. So, therefore, fundoscopy is highly recommended in all these patients, especially in elderly primigravida during the antenatal visits, and there should be frequent follow-up. Secondly, HD-OCT can be used as a routine screening tool in all these patients before any vision-threatening complications can occur. Thank you.
Hello.
Have you asked all the patients to come to ophthalmology OPD to
Yes,
do
sir.
AOCT?
Yes, sir. Firstly, the obstetrician, OBG doctors, they are sent, when they diagnose BP was high, then they sent to us. So that was our first visit. Then we took them at 28 weeks, then after postpartum.
Usually these patients are very
Yes,
yeah,
they are not very
mobile,
cooperative.
yeah,
Yes.
not only
So that
cooperative.
is why we took at 28 weeks. We didn't go far beyond that.
And you, according to your table, only severe cases showed significant p-value.
Yes, sir.
So, in that case, do you recommend everybody should be called for ophthalmic OPD to do AOCT?
See, so my study population, first of all, was 35, and the changes were seen in severe preeclampsia. So I will not like to generalize it to the entire population, but more studies or large prospective studies should be done to find out about these changes.
What are the most significant changes in OCT?
Sir, the RNFL thickness was higher in severe preeclampsia group.
No other finding?
No other finding. Yeah, yes, we could have taken, but I focused in only RNFL layer thickness.
You have not shown any picture of OCT here. You should have shown some pictures, then it would have been more relevant.
Yes, sir.
It's a nice study, but you should have made it.
Yes. On guidelines.
Next,
Thank you.
Dr. Anoop, and he will be presenting on bilateral combined retinal vascular occlusion.
The topic for the day is bilateral combined retinal vascular occlusion on exposure to organophosphorus compounds. Aim was to report a case of bilateral combined vascular occlusion on exposure to organophosphorus compounds. The patient details are as follows. He is a 40-year-old male with occupation pesticide sprayer in forms since 20 years. History. Patient presented to our hospital with a history of diminution of vision in both eyes since 4 months. No issue of pain, redness, flash of light, floaters, trauma, or ocular surgeries. He is an own case of diabetes mellitus type 2 diagnosed 6 months back and is on oral hypoglycemic agents. On ocular examinations, the visual acuity was hand movement positive and projection of rays was inaccurate in all the quadrants in both the eyes. The rest of the anterior segment was normal. On moving on to the diabetic fundoscopic examination, diabetic fundoscopic picture of both eyes showing features of combined vascular occlusion. The red-free filter also showed the same features. Then moving on to fundus fluorescent angiography, the FFA showing the nil perfusion in the right eye, the left eye showing perfusion only around the optic disc, probably due to the development of the collaterals. These are the sequential fundus pictures which were actually taken in the right eye. Then moving on to the left eye. The systemic evaluation was done and the chest X-ray was normal. The random blood sugar was 95 mg/%, the blood urea was 25 mg/%, and creatinine was 0.9 mg/%. The serology was non-reactive, serum electrolytes, the liver function test, and the inflammatory markers, ESR, ECG, were within normal limits, and even the MAN2 test and the sputum CBNAT were negative. The complete blood count was within the normal limits. APLA was also done, and IgM and IgG were both within the normal limits. Then moving on to provisional diagnosis of bilateral combined vascular occlusion, secondary to probably organophosphate retinopathy was thought out. The pesticide sprayed by the patient in form since the 20 years is shown as follows. The treatment, the patient was started on oral steroids with a tapering dose and very guarded visual prognosis in both the eyes were explained. The follow-up visit after 15 days, vision in both the eyes, after 15 days, the vision in both the eyes improved to 1/60 with no changes in the fundus findings. The right eye and the left eye fundus pictures are shown. Patient is on the regular follow-up. Moving on to the discussion, organophosphates are a commonly used pesticides worldwide. All organophosphate pesticides share a common mechanism of action. It mainly includes the competitive inhibition of acetylcholinesterase enzyme, which in turn results in the deacetylation of the neurotransmitter acetylcholine. The inhibition of the acetylcholinesterase enzyme resulting in the lower levels of acetylcholine may interfere with the retinal neurotransmission. Alternatively, organophosphorus may generate free radicals leading to oxidative stress in the retinal neurons and the retinal vessels. The Palm et al. Reported a case of bilateral retinal degeneration characterized primarily by a geographic maculopathy due to the chronic and acute exposure to dimethoate. The Kiran et al. Found an elevated risk odds ratio of 1.9 with a 95% confidence interval is equal to 1.2 to 3.1 of retinal degeneration in wives of farmers who were actually the pesticide applicators. Camel et al. Studied the retinal degeneration using a standard questionnaire. The licensed pesticide applicators were interviewed for the use of pesticides. There was significant risk of retinopathy in the pesticide applicators. Jaga et al. Published a review article on ocular toxicity from the pesticide exposure. They emphasized that unprotected eyes to the pesticides results in absorption in the ocular tissues and potential ocular toxicity. Conclusion, as in the case presented with no systemic illness or inflammatory condition, the possible cause would be chronic exposure to organophosphorus compounds. Due to the guarded visual prognosis associated with the combined vascular occlusions, all the occupants or individuals in contact with the pesticides are required to undergo dilated fundoscopic examination at a regular interval. Prompt diagnosis and treatment can provide the useful vision as in the case presented. Thank you, sir. Yes, sir. Sir?
This exposure was on spraying the pesticide only, not
Sir,
consumption.
not on consumption, sir.
You're only on the,
He's actually the pesticide sprayer in the farm since 20 years. All other investigations, we actually ruled out all the systemic inflammatory conditions, everything, and all were to be normal, sir. So we thought there were some studies saying that pesticide exposure can cause the mainly the degenerative changes in the retina. So we thought it could be the condition, and there is one more mechanism that it mainly affects it causes oxidative damage in the retinal vessels. So it could be the possible mechanism, and the case requires the follow-up, sir.
So what were the systemic effect of this chronic OPC exposure? Were they evaluated?
It was evaluated, sir, but he complained of occasional complaints of diarrhea and all. Otherwise, there were no symptoms, sir, on systemic exposure.
Very strange. Okay, otherwise a very rare case.
Yes,
Yeah. Okay, okay.
Thank you, sir.
Igna.
Should I start, sir? Sir, topic is milder than type 1 retinopathy of prematurity. I think many people are absent, sir, in between. Yes, sir.
Yeah. Okay. Last in the first quiz. Okay.
Should I start? So very good morning to all of you. So topic of my presentation is milder than type 1 retinopathy of prematurity, disease profile and indications of treatment. So we all know that ROP is classified according to our ETROP classification. Type 1 ROP is treated and non-type 1 ROP, which is further classified into type 2 and mild type, is observed. So why we did this study? To study the fate of non-type 1 or milder ROP. 80 to 90% cases regress by themselves. In 10 to 20% cases, we may need treatment with laser, as has been documented in a few studies. These treatment decisions are arbitrary. No standard guidelines are there, neither ETROP nor RBSK has mentioned these guidelines. So the reasons for treatment included in these studies were structural changes, advancing postmenstrual age of the child, and fellow eye with type 1 ROP. So all these were retrospective studies and have been done in developed countries where neonatal care standards are high, as compared to India where ROP commonly develops in bigger babies and as well as older babies. The purpose of this study was to describe profile of non-type 1 ROP and discuss their treatment indications. So in detail, the aim of our study was to describe milder than type 1 ROP in terms of features and staging, morphology, and treatment indications. Pre-plus disease was also studied as a risk factor for treatment. So methods, it was a retrospective observational study on, records of babies were studied from March 2019 to September 2020. RBSK guidelines were used for ROP screening. Inclusion criteria were all infants with diagnosis of milder than type 1 ROP who did not progress to type 1 ROP were included. And exclusion criteria were incomplete data and congenital or acquired disorders interfering with ROP screening or treatment. So the results are as follows. 464 eyes were screened, out of which 187 eyes developed some stage of ROP and were included. 90 eyes developed non-type 1 ROP and 30 eyes of 16 infants were included for analysis. So the disease spectrum was that we saw 3 babies with type 2 ROP, all of which were in zone 2 and stage 3. And mild ROP, we saw 27 babies, out of which 9 were treated. For type 2 patients, all 3 out of 3 were treated, that is 100%. And for mild ROP, 33%, that is 9 out of 27 were treated. So coming to burden of non-type 1 ROP treatment, out of 109 cases in our center that were treated for ROP, 11%, that is n equal to 12 eyes underwent treatment despite a diagnosis of milder than type 1 ROP, as elaborated in the previous slide.
Similarly, milder than type 1 ROP formed 12.5% and 9.5% of treated eyes in studies done by Liu et al. And Gupta et al. So indications of treatment. We saw the most frequent and exclusive indication of treatment in our study was persistent ROP despite increasing baby weight, which formed 9 out of 12 eyes. The mean weight at time of laser in these babies was 3,921 grams. Rest 3 out of 12 babies were treated due to unilateral sight-threatening structural developments. Fellow eyes of all the 3 babies showed complete retinal vascularization. Of these 3, 2 showed anteroposterior traction in the temporal quadrant, risking progression to stage 4 and tractional RD. So these are few of the pictures showing vitreous hemorrhage, persistent ridge with tractional component, and another picture showing a very raised and vascular ridge, which is still persisting despite a not very aggressive plus disease. So these patients we had to treat because the disease was persisting in these. So coming to literature review, many studies have been done, and they have treated, all of these studies have treated babies with structural changes. Then type 1 ROP in the fellow eye, if the baby had the other eye was also treated. Then active ROP at advanced postmenstrual age. As compared to in our study, the exclusive indication was persistent disease at higher weights. This probably we saw because in Indian babies, bigger babies are also developing ROP. So both eyes are done in the same sitting. Often, this is again often an indication for treatment. Why advantages of treating both eyes include resolution of persistent non-type 1 ROP, avoiding inconvenience caused by repeated hospital visits, avoiding procedural risk to the baby, risk of getting lost to follow-up, limited equipment and manpower in our developing country. So pre-plus disease, as I said, was also studied as a risk factor. It was defined in ICROP 2005 and it carries a high risk for progression. These eyes are 2.33 times more likely to be treated as compared to those without pre-plus disease. Also, yes, sir. So just one or two few slides, sir. So novelty of our study was that we have studied these babies with higher mean birth weight, gestational age, postmenstrual age, and persistent ROP despite increasing weight and anticipated difficulty in laser treatment was the most common indication of treatment, which is a novel treatment till now. Never it has been studied. So what lessons we learned? We learned that non-type 1 ROP forms a sizable chunk of treatable ROP worldwide, and tackling non-type 1 ROP is not a simple task, as it warrants either long-term follow-up or laser to the possibly viable peripheral avascular retina. We must stay mindful of pre-plus disease and treat if possible. Simultaneous treatment of both eyes is a good option, and take into consideration the ophthalmologist's expertise in treating heavy babies in order to ensure a thorough treatment and avoid general anesthesia. So thank you so much.
So what was the study duration?
The study duration was 1.5 years.
From here?
So from 2019 to 2020 September, March 2019 to September.
So there was some COVID time during that?
Yes, sir. So that's why I said lot of babies were lost to follow up. We could have included almost 90 babies.
So during COVID time,
Yes,
what
sir.
precaution you took to examine these babies?
Yes, sir. So during COVID time, we ensured that at least the parents were covered their faces with mask. We also covered our faces with mask, and we definitely used indirect ophthalmoscopy. We were at a distance of a few meters from the baby. The baby's face. Often we tried to cover with mask, but it was not a feasible option because then the breath the 20D lens got very hazy, so that was not an option. Mask we could not use for the baby. For NICU babies, definitely it was not a problem because they were often in incubators. So incubator screening is definitely safer as compared to OPD screening. Yes, sir.
So what are the medical legal?
Sir, medico-legal issues, there are a lot of medico-legal issues associated with ROP. But thankfully, sir, we have, touch wood, not come across any such problem. Sir, we take a proper, sir, for all cases of ROP, we are maintaining our files. We are not just giving to the patient, we are maintaining our record in which we properly mention the date when the patient has to be called. If suppose a very high risk patient is there, suppose we are planning to laser the baby, or we are planning to give anti-VEGF, and the patient goes gets lost to follow up. We try to call 3-4 times, like 1 or 2 times we try to call. If they still don't respond, we'll write in our files that we have tried to call and still the patient has not responded, or whether the patient has and we take address and phone number of all the babies and keep record with us.
You treated babies irrespective of the stage of the disease.
Yes, sir.
The treatment of the babies
Yes, sir.
were irrespective of the stage of the disease.
Sir, the typical guidelines that ETROP has suggested, we have treated these babies out of those guidelines. So that's why we have studied these babies. Out of the routine guidelines, we have treated these babies. Sir, I have got 2 pictures, but these are not our pictures. These we have taken. Sir, we have not. We are unable to take. We don't. Sir, we just write the findings on our ROP files. Yes, sir. Sir, actually, we are in a government center. We don't have this thing. Smartphone. Sometimes I'm trying, not very. Okay, sir. Thank you.
At least those patients who have some positive finding, so you need a photograph or some sort of document. ये लीजिए कोई बात